kind of what the common theme that's continuing to emerge from all of our scientific meetings is that, drug development is going forward and going forward fast. More and more companies are wanting to enter into the space, which is really good. And this year, although we didn't have much at SGO about late stage trial reporting, we expect this year to be one that will see several trials come out, both in the frontline and the recurrent setting. But I think in terms of just overall science advancements, probably the biggest news to come out of our meetings this year was actually in endometrial cancer, which was demonstrating that the efficacy of using an immune checkpoint inhibitor for patients with first newly diagnosed endometrial cancer. This was two trials that were profiled in the late breaking abstract, and they were published simultaneously in the New England Journal of Medicine. And we had many authors from the US on both of those manuscripts, one of which was actually originating within the GOG itself. And we've already heard as of yesterday that some of these, or actually probably press release this morning, that some of those are already entering into the regulatory environment in Europe. So a lot of exciting news there, because we will see a change in the standard of care. And one of the things that was really impactful for me and other people at the SGO about those two trials was that the only comment that came in from the audience was from a patient. She didn't identify herself as a patient until she basically went in there and thanked everybody for conducting these trials to make a difference in the standard of care. It really was a drop the mic kind of moment, because it really brings to the forefront of why we do clinical research. This was an endometrial cancer patient who was a researcher, happened to be a researcher, a PhD. And so she kind of shown, and she participated in one of the trials, which was even more amazing. So again, I think that, my mantra has always been that research cures cancer. This is a great example of that. And again, for those of you who've had the opportunity to participate in research, I thank you. But ultimately, that's really how we make these advances. And in ovarian cancer, the big story right now is really in these antibody drug conjugates, as they're starting to percolate through into the recurrent setting right now. But because they're so active, we are expanding the patients that are potentially good candidates for those trials as they emerge. So that we're trying to become less restrictive on the tumor expression of these biomarkers that are trying to drive that. And at ASCO, we will hear about the first of the 5, but 4 that are in similar design clinical trials in the frontline space of ovarian cancer who have an opportunity to have immunotherapy. So that trial called Duo-O will be on display. We already know that the trial is positive. We don't know exactly how much positive and what area specifically is positive, but we do know that it's a positive trial, and that will probably annotate the kind of the frontline approach to ovarian cancer. So there's amazing amount of work going on right now. And we expect this year to have readout from our Mirasol trial, which is the antibody drug conjugate that some of you have participated in that targets folate receptor alpha. That will be a confirmatory trial. And if it's positive, it will lead to it'll lead to a full approval of that drug for us. And we have, as I mentioned, many trials ongoing right now that will provide more context as to where these drugs, these antibody drug conjugates fit. Yeah, in all these conferences, we always get somebody who asks about clear cell and somebody who always will ask about radiation therapy. It's an absolute certainty. So first of all, the issue about diagnosis of recurrence being early versus late. So we have some information about this, even back in the day when we did a study where we randomized patients who had finished their first line treatment with ovarian cancer, and they were negative by imaging and by CA-125 and by physical exam. And then what we did is we monitored these patients until their CA-125 started to rise. Now, at that point, they were imaged to see if they had evidence of disease. And if they found that they did not have evidence of disease, but had an elevated CA-125, they were randomized to continue follow observationally versus immediate impact or initiation of therapy. And everybody thought, oh my gosh, because we found this disease earlier, if we initiated therapy, it would make a benefit to patients. Well, we learned that it didn't, actually, surprisingly. It did not impact outcomes. And if anything, it caused a lower quality of life for the patients who initiated treatment early. The patients that were monitored on the arm that was monitored, they waited for those patients to develop overt signs of disease. And you're like, whoa, wait a minute. You mean we waited till it was visible or palpable? And the answer was yes in that trial. It was very eye-opening to me. One of the things that trial did not address were contemporary medicines, right? So we have different types of medicines that we think we might be able to introduce at that point in time. And certainly that takes kind of surgical intervention off the plate, because patients with small volume disease would be more likely to potentially benefit from surgery. So I do think there is value to early diagnosis, but I don't think it's the magnitude of that knowledge yet has been demonstrated. And we've been working with Natera to try to come up with a research question that could be effectively addressed in the earlier identification of disease versus later. And I'll just to put it into some context, it seems logical that if you find it, when you find this disease at a small state, that we should be doing better than if we find it at a bigger state. And in general, that seems to be true, but it's predicated on whether or not the small and the large disease is actually sensitive to treatment. So patients that don't have, who have resistant tumors, it doesn't really matter if you identify them earlier or later, because your struggle is with the inherent biology of the disease. So I think, personally, the more we know, the sooner we know it is of value. But it's mostly in a research setting because we don't exactly know how to address early changes that could be potentially mitigated by the institution of therapy. So for me, it's nice to know. I don't know what to do with the information. I don't know if it's actually going to impact outcomes versus CA-125 and imaging, but it's certainly a space that needs to be explored, because we have now much more information about the biology of cancer than we did even 5 years ago. And so maybe at that point in time, particularly in a clear cell patient, a patient with a clear cell tumor, these new therapies like these EZH2 inhibitors that are starting to come on might be extremely relevant in a minimal residual disease kind of setting. So it's a complicated answer, but I don't want people to run away with the thought that, hey, listen, it's always better to know early. Yes, two things. So I personally do not treat just on the basis of CA-125 change. I really wait for evidence that the combination or treatment is not working. So even if the CA-125 continues to rise, if the imaging does not show that there's evidence of overt progression, then I continue because I don't necessarily know that the next line of therapy will be any better. Could be worse. Nab-paclitaxel as an agent is very much, as all taxanes, are very much associated with nail changes. Sometimes it's discoloration of the nail. Many times the nails come off. It can be, it may need, if it's severe enough, obviously it may need a break. Since nab-paclitaxel is given weekly, we would just take a break. With given it with bevacizumab, it's harder for the wound to heal. So sometimes that needs to be stopped as well. So that's just something you just have to, as a trade-off between a side effect and the efficacy of the drug. But I think for patients that have a CA-125 is a very good measure of disease. The lead time for finding something on a PET CT scan or a CT scan is usually around 2 to 3 months. So it can predate the actual overt progression. But again, as I said, in patients who we are using these therapies for recurrent resistant disease, you really need to clearly document that the drugs are not working. Because probably the worst thing we can do is to kind of shotgun, in other words, change every month a different regimen. And basically what you breed is extensive resistance in the tumor cells that are there. So I like to, like I said, I like to continue them until I know they're not working, and then make an informed decision at that point in time. Yeah, I'm sure everybody who knows me knows that my bias is always to approach, if you're in good shape, good performance status, and meet the eligibility criteria for a clinical trial, to pursue that. MIRV will be available if you've already screened for it. It will be available if the other trial doesn't work. But I look at, most people say, well, listen, I don't think I'm sick enough for a trial. Well, that's actually the exact opposite. You should do the trial when you're the healthiest, because then you have the best opportunity to respond to treatment if it's going to work. Artistry-7 is designed to be essentially a novel therapy, immunotherapy, against a chemotherapy backbone. And the two middle arms are to sort out the relative contribution of the two novel agents, which is the nemvaleukin and the pembrolizumab. So because those are given together as immunotherapy, the FDA required us to split them off as single agents to see whether or not they work. Now, all of the trials, like any clinical study, will be monitored very carefully for whether or not these are working, even if it's the standard of care, which could be a weekly paclitaxel or another arm that you hadn't been previously exposed to. So you don't lose anything by participating. But if you fit the eligibility criteria, I always try to encourage patients to consider the trial. Outside of the clinical trial, I think mirvetuximab is a great choice, we actually are learning more and more about how a drug like mirvetuximab will be most efficacious and when we can use it. But currently, it's available, and it would be a reasonable option as well. Yeah, that's a good question. We didn't really have a strong rationale for the 3 versus 2, except that one of the criticisms that we ran into with some of our other trials with maintenance therapy was that there were patients who were finishing therapy and then recurring after they finished their treatment. And so what we wanted to do was provide enough coverage of the PARP in this setting to capture most of the patients who would be at risk for recurrence in that time observation period. But there isn't any super strong rationale to 2 versus 3, and personally, in my opinion, there's probably no difference in efficacy of 2 versus 3. In fact, one of the kind of contemporary thoughts are that maybe we can actually cut back from the 2 years. And that's something that we noticed in 2018 with the initial reports of the SOLO-1 trial in patients who carried a BRCA mutation. And so there's some interest in wanting to look at ways of de-escalating therapy instead of escalating. But niraparib's recommendation is to give it for 3 years, and as mentioned, that would cover more than 75% of the at-risk patients for recurrence. So it's a little bit bigger proportion than we saw in the other trials. But the drugs themselves work very much the same. And so I think it does give us some confidence that if we get past that 2-year mark, we're probably in good shape, even if there's some problems that needs to be truncated, that therapy needs to be truncated.
Thanks,
and we should have information on Go First about the first trial in later this year, later in the fall. If a patient so we have some information about this. So if a patient has been on chemotherapy and then was given a PARP for maintenance therapy, and then the tumor grew while they were taking the PARP therapy, and then were treated again with another platinum-based regimen, and then had responded again, there does seem to be a little bit of advantage of retreating with a PARP inhibitor in that space. That information comes from the OREO trial, and that was a trial that was looked at in two different cohorts. One was a cohort of where tumors had a carrier to BRCA mutation, and one was in a cohort of patients that did not carry a BRCA mutation. So it's not a big effect. It's not a big effect. However, there are clinical trials ongoing right now that are using MIRV and another ADC called upafitamab, which is slightly different than mirvetuximab, in patients who have responded to platinum and are now looking for a maintenance treatment. So those are trials that are ongoing right now, and if they're available to you wherever you are, I would certainly ask about that, because that could be an option. That trial is one of those trials with mirvetuximab is called Gloriosa, and the other trial is called Up Next. So those are two trials looking at maintenance ADCs in patients who have responded to platinum, and they do allow for prior PARP, and they do allow for prior bevacizumab. Yeah, so this is we actually have quite a bit of data with respect to this. Although I will say we've never done the trial where we started patients at one dose and randomized them to randomized to a different dose. What we did do in many of the trials was to look at retrospectively how patients did if they required a dose reduction, and all of the trials, all three of the trials in recurrent settings. So this would be study 19 for olaparib, Ariel 3 for rucaparib, and Nova for Zejula or niraparib. All of them basically showed that there was no detriment in efficacy for dose reduction. Now, we did run into problems with dosing at 300 for niraparib, and when we learned that patients that had low platelets to begin with, or were had low body weights, that those patients seem to have a higher incidence or frequency of severe hematological side effects. So what we did is we adjusted the dose to 200 milligrams if your weights are under 150 pounds and platelets below 150, and with that we saw that we were able to mitigate the toxicity and not reduce the efficacy. Now, having said that, we still see that 2/3 of patients require dose reduction to the 100 milligram dose. So, or 1/3 of the patients require a reduction to the 100 milligram dose. So, and we do see that there's still efficacy. So one of the neat things about PARP inhibitors is that they have a wide therapeutic index or window, meaning that if you have to do a dose reduction, it's okay. 100 is at the lower limit of what we think would be efficacious for niraparib. Similar with olaparib, 100 is at the low component of where that might be. Same thing with rucaparib. But the idea is that it doesn't require much enzymatic inhibition to get an efficacy signal. And so I think if you're gaining benefit at 100, then that's fine. Well, like I said, we haven't done a formal high dose versus low dose study, which would actually be important to do that. We also don't know whether or not a loading dose actually is important. Now, I personally don't believe it, but we don't have evidence that if you don't have to give like a high dose to get started and then make the appropriate modification afterwards, that's actually important, because some therapies are like that, where you, for instance, like 5FU, that you have to give a high loading dose, or cetuximab, where you have to give a high loading dose and then reduce the dose for the subsequent cycles. So again, we do in the real world, we make all kinds of modifications that are appropriate for patients. But if you expect to have the same outcomes, you really need to follow what happened in the trials that led to their approval. Okay, and so the trial now that we've seen with niraparib, this weight and plate adjustment seems to be safe to do, and that does reduce the dose from 300 down to 200 for a large proportion of patients. so granulosa cell tumors are very interesting. They're obviously a rare tumor, and it's been difficult to do formal investigation in those patients because with those tumors because they're just so infrequent. So we have done a few, and we're obviously interested in that. Because we're doing more and more next-gen sequencing, we're finding that some of these tumors do have actionable mutations, and they may be rare alterations, but because there are some drugs out there that are available for tumors that have a specific mutation alteration, like a TSC1 mutation, we are able to leverage some of those. So I try to get, for patients who have been treated with standard of therapies for granulosa cell tumors like Paclitaxel carplatinum, or have received bevacizumab, for instance, I always try to get next-gen sequencing on those tumors to see whether or not they're potential candidates for one of these tumor agnostic indications, because we do see them occasionally. But for the most part, we really don't. And so I think if you have access to a clinical trial like TRACK 102, temozolomide, old drug, but one that has some efficacy on certain aspects of the tumor biology, it's totally worth it to try it. But we've struggled to get these trials up and going because they're hard to get done in a reasonable period of time. Right, exactly. I personally don't think so. I mean, they basically use the same Illumina sets. The nuts and bolts about how people interpret the mutational signatures that we see from these testing companies, it's mostly about the interpretation and not so much about what they find. So so if you get for instance, if you get a hit that shows there's an alteration of a specific protein or nucleotide, the question is, does that actually change the protein, and does it change the protein function enough that it actually is important? Mm-hmm. And so that's really in the bioinformatics component, not so much the nuts and bolts of finding it. So some of these companies have a deeper dive into that, but most of the commercially available ones are using very similar type of annotation of the of what they find in the on sequencing. Okay, yes. So yeah. Okay, so you're the index case. Yeah. Well, I mean, it can happen. It can happen de novo, or it can just come through. Either set of parents from any generation back. So, that's that definitely can happen. I think that in the past when we were using PARP inhibitors, this is exactly what we did. We treated it till intolerance or progression. We didn't really have a stop date. What we've learned, I think, in more recent years is that we're starting to quantify what the long-term risk is of taking PARP inhibitors. And there's now some concern for secondary malignancy that the longer you're on these drugs, potentially the higher the risk is for a secondary malignancy that would be unrelated to the ovarian cancer, such as MDS or a leukemia. So in the frontline setting, this seems to be related to BRCA status, so the BRCA mutation carrier or not. In the recurrent setting, it seems to be less so. But I think there is generally concern now that if you don't have anything to treat, that just using it as protection may not be the safest long-term solution. So that's why you're getting some of that hesitancy. Like I said, it's been something we've started to pay more attention to in recent years. If we've had people like you who've been on it for many years that we didn't have before when these drugs were first approved. Yeah, so you can. It's we've run into the situation. I don't know that it's necessarily that it's actually the thing preventing it, because it could have occurred just anyway.
Although and I believe me, I've had this conversation many times for
I'm sure.
from my patients as well, and I understand the concern, but it's I do think that we want to use medications that we know that are actually doing something,
Right.
and so that's and because there is this risk, it's something we assume that there is risk that that there's a potential for a secondary malignancy, and so we just have to be conscious of what that is. Yeah, so our best chance to prevent recurrence in ovarian cancer actually is in the frontline setting with patients getting maintenance. That's our best opportunity. Once the cancer comes back, the biology becomes very mixed and it becomes harder to control. And so it's very common that patients will go through kind of the roller coaster of many recurrences. What's unusual is to be in and out of remission. So it's more common that we see patients going from line of therapy to line of therapy. So it works for a while and then it stops working, then we switch and go to another line of therapy. But to go in and out of therapy and be off treatment and then come back on treatment and then go off treatment, that suggests to me that there are molecular alterations in the tumor, such as a BRCA mutation or some other type of mutation like PALB2 or something that is keeping the tumor still consistently sensitive to these retreatments. And certainly being a diagnosis in 2008 and being at 2023 now would speak towards some type of unusual molecular characterization of that tumor. So that's just that's unusual. What we have learned though is that patients that are we never had this problem when I was going through training. Rarely ever saw a patient with brain metastases. Rarely ever. In fact, most of the time it was due to a new malignancy where they had a breast cancer or lung cancer that presented with it at the same time. It's so uncommon. But now as patients have lived longer and longer and longer, what we're seeing is this natural history disease is that this 10% that we used to never see is starting to see. So we're starting to see it. And so brain metastases are still uncommon, very uncommon in ovarian cancer, but we're seeing more and more patients with them because they are living much, much longer with their disease than we ever saw before. I think that the is a complicated question. So I'm not there's definitely some association between talcum powder on the perineum and the development of ovarian cancer. It's associated. I have been struggling to see the cause and effect. So association and cause and effect are very, very different terms. We have, if you look at the data carefully, it has been really hard to make the linkage between a causative effect and not. I think that the endometriosis is a much stronger causative or predisposing factor for the development of ovarian cancer than we see with talc. If I don't know if you how deeply you get into this story, but I think the way that it's been displayed in the media, the way it's been displayed in the court cases, have been more emotionally packed than by science. But I do think that endometriosis, because of what many factors are engaged in the process of endometriosis, including the true inflammatory response that's produced by endometriosis, does raise that potential for genetic alterations to happen in normal tissue, which can then lead to driving alterations for the development of ovarian cancer. So we've seen that association. The cause and effect, even in endometriosis, is very difficult to prove. But there is, I think, much stronger, compelling evidence with gene alterations between the development of endometriosis and the development of ovarian cancer. So many, many women have endometriosis. Only a tiny fraction of those patients actually ever develop ovarian cancers. The question is why. So I think that it really gets down to severity and the molecular alterations that are driving the early changes in the fallopian tube that we see with endometriosis affecting those tumor cells, or those normal cells, as they become pre-malignant and then ultimately into malignancy. But that process, is governed by, like I said, lots of factors, including local steroid hormones in the tumor microenvironment that we see that are commonly associated with endometriosis. So, like I said, there are associations, but cause and effect is very difficult to prove. Well, it's actually not during stopping. It's actually can happen during. In most cases, it's in the first couple of years, so around 2 years. But I've seen it as early as a few months after starting a PARP inhibitor. But I think there's while there's most of the trials that we've done that have looked at PARP inhibitor versus placebo have not shown an increase in MDS and AML. So when you look at PARP versus placebo, you don't see statistically a very big difference in that. Now, there are some nuances to how this is calculated and how long patients were followed to see the development of it. But in general, it's about 2 to 2.5 years. And it happens without PARP inhibitors. So I hate to make PARP the kind of the evildoer in this process. It happens with chemotherapy, particularly with platinum, which is what almost everybody gets, maybe more than once with ovarian cancer. So the platinum agents can be strong inducers of this same process. And for those of you who maybe have been around around the ovarian cancer environment for a long time, might remember that one of the reasons we did second look laparoscopy or second look laparotomy after completion of a certain number of cycles of chemotherapy was to prove that we didn't need to treat indefinitely with chemotherapy, because patients who are on long-term chemotherapy were developing this MDS AML, and we wanted to stop treatment so that we wouldn't provide too much inducement of those problems. That was well before PARP inhibitors were ever introduced into the clinic. Yeah, great question. And it is a little bit dependent on whether or not you carry any of the genotype or the phenotype in the tumor that would make you a good candidate for that. So for patients who carry a BRCA mutation in the tumor, whether it's from the germline or not, the probability of recurrence at any point in time is described by what we call the hazard ratio. And it's a complicated math term, but in that trial that looked at olaparib for patients who got it up for 24 months, the hazard ratio was 0.3, which means that there was a 70% reduction in the probability of progression if you were taking the medication versus placebo. Okay, so, but the question you're asking is slightly different. Even though we can look at that going forward, that 70% reduction is based on the number of patients that actually are at 3 years. And so if you look at that point in time onward, the probability of recurrence is actually low. It's not zero, but it starts to really flatten out around 5 years or so. And between 5 and 7 years, we see maybe only a 2% of patients actually progressing at that point in time. So what I've started to talk about, is when we talk about the term of cure, which we almost hardly ever talk about, with ovarian cancer, because it's such a difficult disease to treat, but it's also a very difficult term to define. So when I ask people on this call, what is your definition of cure? It's usually something, well, the tumor didn't come back in fill in the blank number of months, right? Or, well, my tumor is gone after I finished my first line surgery and chemotherapy, so therefore I'm cured. And what I can tell you is that when we tried to address this question a few years ago, Dr. Sud and I, And what we decided to do was to look at normal mortality rates in the general population that were due to non-cancer reasons. And so what we did is we took the data that was available in the United States in ovarian cancer patients, and we adjusted them for age. And then we tried to statistically compare the mortality risk for patients who had ovarian cancer versus mortality risk for the patients who did not have ovarian cancer. And about 9 years after treatment, we could no longer tell the difference between an event that occurred because of a cancer or an event that occurred because of a non-cancer. So while the risk is lower as time goes on, and there is protection based on the medication that is, as I mentioned, is a 70% reduction for probability, we start to run into a place where we can't actually tell the difference between an event that occurred because of disease or not. That occurs further down the road. Yeah, and this is a good question. This came up recently in another conference I was speaking at. So there's a difference between lack of progression over time and overall survival. So they should seem like the same thing. But when we talk about that from a standpoint of a clinical trial, overall survival is comparing all cause. So whether you've recurred or not, they're just looking at the number of patients that are alive, let's say at 5 years, as you just mentioned. In that discussion, when we talk about cure, we're actually talking about our patients predominantly in the frontline setting that have never recurred. So never recurred. And so, yes, if you look at the 5-year never recurrence rate, it goes down kind of in almost like a hockey stick, like it's an kind of this L shape or a curvilinear kind of design. And so when you get out here around 5 years, you're on the flat part of that curve. Now, it doesn't go to 0 at that point in time because there is a 7-year recurrence rate and there's a 10-year recurrence rate, but the rates are almost 0 at that point in time with respect to what the likelihood that will happen at that point in time. And as mentioned, if you look at the same age of patient who has been on without recurrence for 10 years and the same age of patient who never had a diagnosis of cancer, the rate of mortality is essentially the same. And that's where we're kind of starting to say that those patients don't have a higher risk of mortality due to cancer. They still have obviously all the other issues that happen to all of us as we get older, but at least it's not a cancer-related issue. There's no additive increase because of cancer. Oh, yeah, it depends on the study. Some of our trials, for instance, the paclitaxel carboplatin studies that we did, 5 years was started at the point of enrollment on the trial. So that was before the first cycle of chemotherapy. For the maintenance trials that we've been talking a lot about today, those are usually indexed at the point of when patients were randomized to either treatment or no treatment. So that would be after the completion of chemotherapy. So it really just depends on, what reference point we're talking about. One of the things that we kind of forget about is that not everybody who starts on chemotherapy after surgery, let's say, or after neoadjuvant chemotherapy and surgery, respond. So some of those patients actually go on to have persistence of disease or incomplete resolution of disease. And some of those patients never really even get onto some of these trials that we're talking about because they never really had that kind of response to treatment. So when we talk about the 5-year time points, if you look in the statistics that you'll see online, many times they're just looking at all cause mortality rates from all patients with a diagnosis. So we say right now that the median overall survival, so that's the middle part of the overall survival curve, the middle part of that now for ovarian cancer patients is around 5 years. So, but that comes with all of the caveats that they could be with disease, without disease, on treatment, off treatment, on PARP, off PARP, all cause. the bottom line is don't worry. So first of all, I mean, letrozole, we sometimes I feel like hormonal therapy, if this is ovarian cancer, sometimes I feel like hormonal therapy is almost more treatment of the doctor than the patient, because we really don't understand the hormonal axis for ovarian cancer, for the high-grade serous ovarian cancer. Now, for treatment of tumors like that may be endocrine active, like in granulosa cell tumors or low-grade serous tumors, there may be more, impact of therapy, but losing a day or two is not a problem at all. In fact, some people take a couple of weeks off because of fatigue and other issues that are difficult to maintain with a drug like letrozole. Yeah, I think one of the issues about endometriosis is that it is hormonally active. So and so if you have ovaries, then those cells that are these endometriotic cells, which basically are just uterine tissue that's outside of the uterus, then they'll go through cyclic changes just like anything else. But if you don't have ovaries, that's the treatment. So it takes away that axis, and generally those tissues scar up pretty quickly, and so are no longer much of a problem. Yeah, there are a panel of markers that can be looked at, but there are definitely cases where CON25 just isn't expressed by the tumor itself. So in general, if we don't have a good marker to follow, then we'll just use exam and imaging, as a way to monitor. In some, relating back to the Natera question before, there may be some circulating tumor cells and circulating DNA that may be used as a potential new marker for monitoring patients. But it's worth it to find something that can be easily done on a routine, repeated basis, and doing something like circulating DNA would be a little bit more problematic to do on a serial basis for monitoring. Oh, this is myelodysplastic syndrome, which is it's a range of different types of diseases that affect the bone marrow and the cells that originate from there. Many times these become malignant and turn into what we call a myelogenous leukemia, which can be like any other leukemia. It usually comes in acute forms. So there are definitely situations that we need to deal with.
Thank you. And then there's the last question, which is asking, what is the role of ctDNA with ovarian cancer?
Yeah, this is what I just mentioned about circulating tumor DNA, that these are ways of potentially identifying abnormal DNA that's floating in the bloodstream. We are getting better at making sure that these are true and related to the tumor and not just related to other heterogeneous findings within the bloodstream. But we don't, again, we're still in the process of trying to understand exactly how they fit into our treatment algorithms for ovarian cancer. But like I said, it's part of our research strategy of trying to figure out better ways to monitor and treat patients. Yeah, I mean, it's reiterating what we've seen over and over again, that we used to say, when I was a resident, we used to say, the longer you live, the longer you live. And this is true because patients that are on clinical trials, they gain benefit from those trials. We don't always get that, but when they do, they participate in clinical trials, first of all, they get better overall surveillance and care because they're guided by a protocol. If it shows benefit, those patients then have an opportunity to live longer for the next discovery. And so what you see is the stacking of PFS events that can lead to a longer overall duration of survivorship. It doesn't always work that way on a patient level basis, but it certainly can on an individual basis, depending on the disease and the type of drug and all those other things. So, but the opportunity is zero zero if you don't participate. So, and again, all the drugs we've been talking about, the PARP inhibitors, the antibody drug conjugates, the Avastins, all these medicines that we've talked about, immunotherapy, they all got to us because we asked a question, you participated, it changed the landscape, and we move forward. So I think, obviously I'm a huge believer in this, but I'm eternally grateful to people who have donated their, donated their time and effort to continue to help us answer these questions.
Thank you.